Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, fully occluding earwax, but also extremely hardened keratin, so dead skin. And this is their left ear. This is the worst one out of the two. And they attended alongside their niece, who brought them along. The patient really was struggling to hear. And in fact, the niece had to arrange the appointment on behalf of the patient. And she had been really struggling to hear, to the point where the TV volume is extremely loud and the niece is not able to tolerate it anymore when she goes to visit. They have a chronic issue with earwax impaction, and in the past have had it irrigated, so with water at the GP practice, but most GPs in the UK no longer offer earwax removal services. So this patient was recommended to visit myself, and you can see that I've already removed a huge portion of wax and dead skin, and it has slightly discolored. It's more white and a pale yellow in appearance, and in part that's due to this being a higher concentration of keratin, so dead skin, as opposed to earwax. But also the patient has been using some hydrogen peroxide drops, and they can sometimes lead to discoloring of the wax. So I've removed the occlusion, but there's one area of concern for me, and I'm going to show you that in a moment. I'm going to freeze that. There is some drops very deep in the ear. You can see here. So the drops had seeped through, and it had actually got trapped in behind the wax and keratin plug, and it's just on the eardrum. I'm going to suction it away. But this area here, I'm going to freeze this section in a moment, just to the left where the sucker is. This is an area of concern for me. It's a rock solid piece of keratin, and I want to know what's underneath that, because potentially this patient could be suffering from a canal cholesteatoma. They are very, very rare. I'll explain what a canal cholesteatoma is in a moment. It could also be osteoitis, so just an inflammation of the bone. So we really need to unearth what's going on behind that. It is challenging because the patient wasn't always still, that they were doing their best. And because we're working so close to the eardrum and on the bony part, I was a bit hesitant at first to explore that region anymore, but the patient was so they were tolerating the procedure so well. I was a bit concerned that it might be a bit uncomfortable for them as well, because obviously that sensitive region that if you've been watching my videos, I always explain that the inner 2/3 of the ear canal is extremely sensitive to the bony part. So I've just circled that. The patient's hearing loss has been alleviated. All the other associated symptoms that they attended with have all but been relieved of, but I just want to see what's underneath this. And you may have seen the camera just shook there slightly. The patient just slightly moved because of the noise. I had a bit of clarinetting, so when you suction dead skin, you can be prone to the skin vibrating against the tip of the sucker, and that just startled the patient slightly, but they were okay to continue. And if I had the audio on during the procedure, when I'm making contact with this, you can actually hear it ping. That's how hard it was. And I'm just working around. At the same time, I've got one eye on the patient. It just blocked the tube there. You might have seen, I've actually just had to redraw the suction probe. It just got reduced suction power. So it's just come out, just cleared the suction probe. Because it was quite hard, it got trapped at the entrance of the sucker. So I've always got one eye on the patient here. And you may see that the tip of the suction probe, the fine end that I'm using, I've just bent it slightly so it can go in downwards. I'm almost sparring with this. I want to see how much force it's got. Again, I've just always got an eye on the patient, but they were fine. Not to spoil it for you guys, I did remove the majority of this, and there was an ulceration, so some exposed and eroded bone, and it created a little cave in this region, and dead skin had collected inside this erosion, this widening where the eroded bone is. And when dead skin collects in that, it can form and harden just like this, and it can lead to a canal cholesteatoma, which is if left untreated, can be quite dangerous, potentially life-threatening, because that cholesteatoma, it can then cause disease of all the bone, the temporal bone, and that can then spread to the mastoid bone, and it can go to the skull base. It can just spread all around the patient's head, and so hence why I wanted to remove this. I want to see what's going on. Alternatively, it could just be a bit of benign osteoitis, so just an inflammation of the bone. So that could just be treated with medication. But I have referred this patient to their GP, and I have recommended onwards referral to an ENT specialist so they can examine further. There was some hardened keratin still left in there. That would need to be softened with some sodium bicarbonate drops prior to removal. It's too deep in, and that would be really uncomfortable for the patient to have removed. Normally, when there's concerns about potential canal cholesteatoma, a CT scanner is ordered, and sometimes surgery is recommended. It's not always possible to remove this in an outpatient's appointment like this. It has to be done under surgery, because I just don't know how deep this is, how much it's embedded. And I have come across quite a few canal cholesteatomas over the last couple of years. Some regular patients of mine who've had to undergo extensive surgery. I know they would be watching this video, because I know they're a avid follower of mine on social media. So I just want to, again, you can't see that ulceration at the moment, but it will become apparent, and then there's some underlying granulation tissue there. See here, I'm just digging it out, and that when I felt it with the tip of my fingers, it's rock solid. So you are beginning to now see the erosion there and the hard keratin that's embedded. Think about it like a crater. That's another way of visualizing it. So the ear canal more or less should be quite smooth. Shouldn't really be any indentations or potholes, or another way of describing it. It's like a pothole crater there. And now you can see some of that granulation tissue. You can see some of this damp, dead skin that's around it, so I'm pretty confident it's infected. And I just want to go into it, almost chiseling it out. And this sucker is just gliding on the surface of it. It's so rough and so hard. It's not something you can just go in with an ear hook and pick out, because that will just be extremely uncomfortable for the patient. And we're so close to the eardrum. One false move by myself with the instrument, the sucker, I can quite easily pierce the patient's eardrum and perforate it, or indeed one false move by the patient, and I'm not quick enough to be able to adapt. Similarly, we could pierce through the patient's eardrum and cause a perforation, which is the last thing we want. So I'm just mopping up some dead skin just around the midsection of the ear canal. So that's how a canal cholesteatoma forms. They are very rare. It's just when dead skin, keratinized skin, so when the skin on the surface of the ear canal dies, it's filled with keratin, which is a protein. We also find that on our fingernails and on our hair strands. And the ear has evolved to shed itself of all the dead skin that collects in the ear. Otherwise, all of our ears would be full of dead skin, and we'd all need to have our ears cleaned on a regular basis because of the skin collection. So the skin, as it dies and it sheds, it fills up with keratin, and this skin should migrate, should move sideways out of the ear like a conveyor belt. But in this patient, it hasn't, and it's the skin, as it's migrating, it's fallen into this cave, this little pothole, and it's gathered and it's hardened, and it can start infecting the bone. So we need to get that checked out. So we just move on to the patient's right ear. Again, there's a higher concentration of skin. There is some wax here, but there's also a lot of skin. You can see that skin, it's glossy skin. Keratin has a very reflective property. It also helps to reflect harmful UV rays from the sun. So keratin has got, the protein keratin is very useful. So 90% of the skin cells of the ear canal are what we call chenocytes. So during their life cycle, they eventually fill with keratin, the protein. We call that process cornification, if anyone's interested. So the outermost layer of skin that lines the ear canal, we call that cornocytes, skin cells. and they were originally canocytes. And during the life cycle, these canocytes modify, they change structure and physiology, and when they are pushed upwards towards the surface of the ear canal, they lose all their cell function, all the intracellular fluid, all the organelles within the cell are no longer present, and instead the dead skin cell, cornicites, they're cornification, that's hence the name, and they fill up with keratin. And keratin is hydrophobic, so it helps to prevent water from penetrating and macerating the skin if it's exposed to water. As I said, keratin helps to reflect harmful UV rays. It can also act as a physical barrier for harmful bacteria and fungi to penetrate a deeper layer of skin. You can already see the patient's eardrum just in the anterior recess. Again, there was a lot of dead skin. It was quite firm and crusty, so I've had to just use the fine end, angled it so it's going into that anterior recess. It kept getting blocked, I had to keep coming out. So it's a bit tricky, this part, is so close to the eardrum. Again, I don't want to perforate this patient's eardrum, I just want to hover over. Similar to the patient's left ear, I just want to remove as much as I can because I just don't know what's behind this. Given that they've got that ulceration in their left ear, I just want to be sure there's nothing hidden away here in their right ear. So I'm just going to make a concerted effort just to remove as much as this as possible. Now, what I'm removing is not really going to necessarily improve the patient's hearing. And at times the patient was slightly unsteady, but again, they were doing really, really well. I managed to remove some there. I kept having to come in and out of the ear on this side because the sucker kept getting blocked because of the consistency of the skin. So if a patient attended and they had this amount of residual skin or wax deep in the ear and they were complaining of hearing loss, I would be skeptical as to whether this would be the cause because you can see the eardrum, the majority of it. But sometimes when you perform procedures, it's more for diagnostic reasons, to look for underlying pathologies. So in the past, there's been like a layer of dead skin on the posterior superior quadrant of the eardrum, so near the attic basically, which wouldn't really affect the hearing, but that region of the eardrum is where you can develop a typical cholesteatoma. So we talked about a canal cholesteatoma earlier. They're quite rare. Cholesteatomas are rare in general, but especially a canal cholesteatoma, which forms within the ear canal itself. The more commoner form of cholesteatoma, although, as I said, it is rare to get that as well, they're found at the top of the eardrum. A sack of dead skin collects in a retraction pocket, then it can grow inwards into the middle ear and upwards towards the brain or towards the antral of the mastoid, to the bone behind the eardrum. And sometimes, if possible, if there's a bit of dead skin in that region, I try and peel that away just to see what's underneath. And there has been occasions just through the removal of that skin that I've noticed there is a cholesteatoma forming. But probably in my earlier days performing earwax removal, these are things probably I wouldn't feel comfortable doing. But it just takes experience and performing many procedures where you can build your confidence and be able to do things like that. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.